Hi, good morning. Welcome to our discipline group, psychosocial discipline group this morning on adjusting and thriving after CFRD diagnosis. Feel free to continue to get something to eat and have a seat, but we're just going to go ahead and get started with some quick orientation here today. So I'm Carolyn Snell. I'm a psychologist with the CF Center at Boston Children's Hospital, Adult and Pediatric Centers, and I am co-chairing along with Diana Naranjo from Stanford, who is also going to be one of our speakers. As I'm not one of our speakers, I'm going to quickly orient us today and also run the Q&A at the end. First up today, we're going to have Dr. Melissa Putman, who is an endocrinologist at Mass General Hospital, who's going to be giving us an orientation to CFRD and its management from a medical perspective. And then we're going to have Diana Naranjo talk from a psychology perspective about sort of the psychological impacts and burden of living with CFRD. Then we're going to have Dr. Michael Harris from Oregon Health Sciences, who's going to be talking about how we as psychosocial professionals can help people to manage their CFRD and manage some of the behavioral aspects of that. And then lastly, we're fortunate to have a patient partner from our center, Noor Elshar, who's going to be finishing things up by sharing her own experience as a person with CFRD. So we will welcome up our first speaker. The other thing I wanted to say quickly was that we are going to be doing question and answer at the end of all of the talks rather than the end of each one. But please, as you go, you can open up the question and answer, down here at the bottom of your app within the session. And please go ahead and type in your questions as we go, and then we will address them at the end. Thanks, everyone.
Excellent. Well, thank you so much for the introduction. And I'm so excited to be here. So I am an adult and pediatric endocrinologist at Mass General Hospital, and I also work closely with Boston Children's and the Brigham and Women's program to take care of patients with CF and CFRD. And I think the idea behind me going first is that I really want to set the stage for you in terms of what people have to go through and what it's like to get this diagnosis and what all comes with it. So that's the idea behind it. Here are my disclosures. So I want to start by giving everyone just a little background about CFRD and then talk with you about my approach when I talk with patients about a new diagnosis of CFRD and everything that entails. And ultimately, I really want to give you an understanding of the medical complexity, the challenges that come with a new CFRD diagnosis. So as you probably know, CFRD is one of the most common non-pulmonary complications of CF. And so this is data from 2023 from the patient registry showing that really, right around the adolescent years, up to 20% of people can be affected, and then closer to 40 to 50% of adults will get CFRD. And when I talk with patients, what I say is, that really there's so much we don't understand about why CFRD happens. But what we know is that the cells in the pancreas that make insulin, the beta cells, they stop working. And we don't really know exactly why. It's probably very complicated, as you can see in this slide. But multiple things, including exocrine pancreas disease and insulin resistance, multiple things coming together to affect insulin secretion, to cause insulin deficiency and high blood sugars. And there are multiple ways that we can make the diagnosis of CFRD, and often how we treat it and how we talk with patients will depend on how they're coming to attention. So one way is with screening, with the oral glucose tolerance test. And so in this case, someone has the OGTT, their 2-hour glucose is above 200, which is consistent with diabetes. When someone comes to me from this perspective, often this is kind of earlier in the course of dysglycemia. Often they have normal fasting blood sugars and they're just having high blood sugars after meals. And then someone can also be diagnosed with CFRD if their hemoglobin A1C is above 6.5%. So hemoglobin A1C is a measure of average glucose over the past 3 months. and a 6.5 value is diagnostic. Now, often if someone's coming to me with an A1C that's elevated, this is a little later in the course of CFRD, and so they may actually have fasting hyperglycemia in addition to those excursions with meals. And then, of course, someone can come to attention with very high blood sugars and symptomatic hyperglycemia, where they're having polyuria, polygypsia, they're losing weight, and they're having blood sugars that are often persistently high. And this happens very late in the course of CFRD and often requires a much more intensive management. Now, someone may also be diagnosed with high blood sugars while they're being treated with steroids, which, pulmonologists love steroids, endocrinologists, we hate steroids because they make the sugar so high. And sometimes someone may just need treatment while they're on steroids, but sometimes it actually will continue even when the steroids are stopped. And another time I'll often see patients with the new diagnosis of CFRD is after lung or liver transplant. And this can be particularly complicated. Often this is because of steroids and medications that happen after transplant, but this is coming at a time when someone is really, just trying to get a new normal, learn all their medications, their rejection medications, so many other things, and then we add diabetes to their plate, and that can be very challenging. And there's also the case where I'll be referred a patient who is losing weight, their BMI is low, they're having pulmonary decline, CF exacerbations, we don't know why, and maybe could high blood sugars be contributing? And so that's someone where I actually really want to be able to start insulin because I know that insulin could potentially help them. In all of these cases, my first step personally is to collect more glucose data using continuous glucose monitoring. It's so helpful to guide our therapy moving forward. And so we'll talk a little bit more about CGM a little bit later. All right, so when I'm talking about a new diagnosis of CFRD, I like to highlight just a little bit about why is it different from other forms of diabetes and why is it important? Why do we care about it? And so, I tell people, well, CFRD does share some aspects of both type 1 and type 2 diabetes. And most people know somebody who has, one of these forms of diabetes. And so, type 1 diabetes is an autoimmune condition. There's usually an abrupt onset. That's kind of different. But similarly, there's insulin deficiency that happens in type 1, and the typical treatment is insulin. And now type 2 diabetes, we will often see that in the setting of obesity, and there are non-insulin therapies that we use, and that's a little different. But like CFRD, there's insulin resistance, and it does tend to have a slow and subtle onset. But there's also a lot of things about CFRD that are different and unique challenges that come along with CFRD. So there's a much more distinct progressive beta cell dysfunction and also insulin dysregulation that can predispose to frequent hypoglycemia. And that's different and challenging. There's also a highly variable clinical course. So I have some patients who are on just a few units of insulin with meals, and then others who are on 100 units a day and anywhere in between. And then even within the individual, their insulin needs will often change. So especially if they get sick or they go on steroids, they need much more insulin than when they're healthy. And then often we're fighting undernutrition, not always, but often. And that also is different about CF. And the reason that we care, the reason that CFRD is so important is that we know that the diagnosis of diabetes has an impact on CF-specific clinical outcomes. And how I explain this to my patients is that, well, when the blood sugars go high, then there's glucose that appears in the airway surfaces. Bacteria love glucose. And so those elevated sugars can increase the risk for infection and inflammation. And then this can go on to increase insulin resistance and make the blood sugars go even higher, and you can get into this vicious cycle. And so it's not surprising that the diagnosis of diabetes in people with CF has been associated with a decline in BMI, with compromised nutrition, with reductions in pulmonary function, increased risk of CF exacerbations, and earlier mortality, particularly in women. And this is in addition to all the other things that diabetes can cause in everybody, including micro and macrovascular complications like eye, nerve, and kidney disease. And so it's important, and it has a significant impact on health, and that's why the management is so critical for our patients. Okay. And so once we kind of cover that, then we talk about treatment, how CFRD is treatment. And often I'll get questions, is there anything I can do to avoid insulin? So the first thing I'll say is that in my experience, there's just such a range of how people are kind of are able to accept this diagnosis and where they're coming from when they hear that they have diabetes. Where I have some people who've been dreading this diagnosis for their whole life, and this is such a huge, overwhelming thing for them to face, which is really understandable. And then others who are, able to, okay, what do I do? We'll move forward, and everywhere in between. And so what I start with is really, you now are part of the diabetes team. And so we now have people here to support you, and with me, an endocrinologist, a certified diabetes educator, our nutritionist. For some centers, that's going to be the CF nutritionist who's really working from a diabetes perspective, or in others, it might be a diabetes specific dietitian. We have social workers, psychologists, everybody to help support you to move forward and manage this new diagnosis. But, and I also talk about, the treatment options. And so really right now, insulin is the recommended treatment for CFRD. That might change moving forward, but right now, insulin is kind of what we have. And the reason that insulin is this recommended treatment is because the treatment with insulin has been shown to improve all the bad things that diabetes can cause. It can improve nutrition, help with weight gain, and pulmonary function, and indirect data even suggests a survival benefit. And so that's the reason why we've chosen insulin. And our treatment goals are the same for CFRD as what we use for other forms of diabetes, including type 1 and type 2 diabetes. But the fact is, insulin is hard. And insulin, there's a lot of tasks that come with starting insulin therapy. So the first task is glucose monitoring. And so we talk about different ways to check blood sugars. And this is like the old school way. I feel like I'm like aging myself because when I started, this was all we had. You finger stick checks, get some blood, put it on this, little test strip, and it gives you a number. And we still need this. We still use this. And some people prefer this. But we also have now new tools that make glycemic monitoring so much easier and more comprehensive, which is continuous glucose monitoring. So there's a tiny filament that goes underneath the skin, and you wear the sensor on the back of your arm, and it sends all this information to your phone, including the direction the blood sugar is going. It will alarm if blood sugars are high or low. And it gives me, as a provider, really detailed information to understand exactly what is happening with blood sugars that helps guide how we use insulin. The next task is nutrition. And for many people, it's going to be a change in what they normally think and do when it comes to nutrition. And so we know that high sugar foods like candy and soda and juice, they just lead to these spikes in blood sugar that are really hard for insulin to manage, even with our best tools. And we also need to shift our thinking to more balanced meals where we're combining fats, proteins, and carbohydrates together to really help try to, keep the blood sugar fluctuations in a more manageable way. For a lot of people who've been told early on, it doesn't matter what, just get calories, we just need you to gain weight. It's a big adjustment to make, and that can be very challenging. And the other aspect that we also do is something called carbohydrate counting. And that's where, we teach people how to look at the meal that they're eating and figure out the grams of carbohydrates it is, and then they can use that information to guide their insulin dosing. It's a really nice way to be able to match what they're eating with the amount of insulin that they need. Not everybody does this, but I have found that it's actually really helpful when we're especially starting out with insulin therapy. And then finally, there's insulin. And so, we teach people how to give the injections using a vial and a needle as backup. And then we, a lot of times, will then move on to insulin pens, which are more convenient. And we teach people the different types of insulin. Some are long acting, some are short acting. And we teach people, well, when you're eating, we'll give, a dose of short acting insulin to cover the meal and teach you how to carb count and decide exactly how much you should give. And then, and that's really for many people will mean an injection, 3 or 4 times a day. Some people will need long acting insulin, and that's 1 injection a day. We teach how insulin can cause low blood sugars and how to treat that. Once, usually a little bit farther on in the process, we'll start talking about insulin pumps for people who have a significant insulin requirement, and we think that could help make diabetes management easier. But it's a lot to learn. And, this is a lot, but this doesn't even begin to capture everything else, all the other things that people with diabetes have to think about after this diagnosis. And these are things that we kind of learn as you go. So how does my blood sugar respond when I exercise or when I'm sick? For kids, we need school orders so that the nurse can give insulin at lunchtime. And how is this going to fit into my work schedule if I'm, driving a truck or flying lots of different places and having to travel? And, many of our patients with CF, already have a bunch of different specialty pharmacies and get their equipment from all these different places. Well, with diabetes, it's even more supplies from different suppliers and more things to worry about and refills and PAs and all of that. There's also hypoglycemia that can happen that can be dangerous, and people really can fear that, and that can sometimes get in the way of getting good blood sugar control because we're so worried about having lows. There's also the constant alarms that come on your phone when your blood sugars are too high or too low, and then maybe also from your pump. And if you're sharing your data with your spouse or your parents, then they're getting those alarms too. There's also family stressors. So a lot of our young adults who are going off to college, they don't want to think about diabetes, but their parents really want them to think about their diabetes. And there can be a lot of challenges with that. There's also, unfortunately, sometimes you can think, oh my gosh, the blood sugars are high, and have that high blood sugar is bad, and make people feel bad about it or feel like they're being judged that their blood sugars are not under good control. And then, of course, there's symptoms of high and low blood sugars that just make you feel bad, and having to face all of this is a lot. And so what one of my patients told me is that, when it comes to CF, I can turn off my thinking about CF and do things and not always think about it, but I can never turn off thinking about my diabetes. And so when I am seeing my patients, and I really, especially with a new diagnosis, I really try to customize, individualize my treatment to each person and try to introduce this in a way that is going to best integrate into their life. The earlier we have the diagnosis, the easier it is to do that. When someone comes very late, it's harder to do that. And so that's why early diagnosis can be so helpful. And so first thing I'll do is start the simplest regimen possible. So if someone is just having high blood sugars with meals, and really it's just dinner that's causing the problems when we're looking on CGM, maybe we'll just start 1 short-acting injection a day at dinner. Or if someone's having elevated fasting blood sugars and the blood sugars aren't going so high with meals, maybe we'll try just ease them in with a once-a-day long-acting dose. So we're really trying to match to each person where they're at, what their blood sugars are, how we start insulin. And also, I work with my patients to try to fit insulin into their life. So is it a kid who's at school but doesn't have a school nurse to give insulin? Okay, we'll use, MPH in the morning, and so you won't need to give that injection. So really trying to make it fit into each person's life. And that may also include, kind of moving into pump technology earlier. And so thinking about these different technology tools that can help to make diabetes management just a little bit easier or more convenient. And then I also try to set expectations. So you're going to have high blood sugars. You're going to have low blood sugars. Our goal is so that they're not too high and they're not too low, and that overall they're in a good range. But, it's okay if that happens. And when you get sick, we're going to have to work together to make changes. to get your blood sugars under control. And it really is kind of just making sure people know that, that's okay. And then for me, frequent follow-up visits has been also really, really important. And for me, a majority of my practice is actually virtual because nobody wants to drive all the way into Boston and fight Boston traffic just to see me. So virtual visits, I can see people easily on the computer. We can make adjustments. I can see their CGM data. And that kind of support, I think, has been really helpful. So I also get the question, can I do anything to avoid needing insulin? In the past, I was like, well, for most people, we really do need this. But more recently, in this post-ETI era, the phenotype of people who are getting diabetes is changing. And so if I have a patient who, say, screened with the OGTT and we do a CGM data collection, they're having minimal hypoglycemia, their lung function is great, their BMI is right where we want it to be, that might be somebody that, we kind of ease into this and we start with, just doing the glucose monitoring tasks and the diet changes really to kind of really monitor over time rather than start insulin right away. And if someone is overweight or obese and has evidence of insulin resistance, well, I actually don't want them to gain more weight with insulin. And so that might be someone we start with metformin or a GLP-1 receptor agonist. And so things are changing. And this, I think, highlights the importance of kind of just targeting treatment to each individual. So to summarize, I hope I've convinced you CFRD is a unique form of diabetes with unique challenges, and our treatment for people with CFRD has to be different than what we often do for people with type 1 and type 2 diabetes. Insulin is our recommended therapy, but it adds a significant treatment burden to a patient population that already carries a very heavy treatment burden. And so our therapy and our treatment approach really needs to be individualized to each person depending on what their blood sugars are doing, what their clinical status is, their lung function, their BMI, and then where they're coming from, what their mindset is. And then finally, support from a multidisciplinary team is key. So endocrine, diabetes, pulmonary, psychology, social work, nutrition, everybody really coming together to help support people with this new diagnosis. Thank you.
Thank you so much. I always am wanting to bring you into psychology. I'm like, you're such a psychologist, even though you're an endocrinologist. All right. So, okay. No, this is not mine. That will be... Okay. So that sort of is a great segue into my role as a psychologist in both diabetes and CF-related diabetes, and how to navigate a new CFRD diagnosis. And so really thinking about how this will impact the emotional acceptance and the emotional experience of people living with CF-related diabetes. I have no disclosures. And as Melissa was saying, diabetes can be really tough. It can be tough for a lot of different reasons, but treatment is both a physical task and a mental energy task. People spend a lot of time thinking about, worrying about, constantly on the mind, like her patient was explaining. And it takes up physical time. We'll go a little bit more into depth about all the different types of time-consumingness of diabetes. It's disruptive of your daily life and your regular activities. There's no break, although with CFRD, there's a little bit of a break at times, but there might not be a break of worry, and it all really takes a toll. So that's where your psychologists and your social workers are able to step in and help. So talking about the demands and how they take a toll, I sort of like to think about diabetes and its impact in this added burden, distress, overwhelmment, conflict, fear, and worries vein. And so for added burden, you're thinking about insulin And you're not just thinking about insulin as in when do I need to take it today? I've been diagnosed, but you're thinking, will my child ever need to take insulin? Will I need to take insulin one day? If you are then prescribed insulin, you're thinking, okay, is my insulin the right temperature? Do I have enough of it? It's very, very expensive. Am I going to be able to afford it? I have to get it from these different sourced pharmacies. Is my kid going to remember it? Are they going to leave their backpack somewhere out in the hot, hot sun in the middle of California, and then all of a sudden they no longer have insulin? Are my family members going to be able to help now with my child and helping take care of my child because they're on insulin? Constantly thinking about blood sugar checks, and I'm also dating myself in that I have a blood glucose monitor, but the CGM monitors are more accurate. But both of them, more updated, not more accurate. You get every 5 minutes a reading, but both a continuous glucose monitor and a blood glucose monitor give you a ton of information, and sometimes you don't know what to do with that information. So you could have information overload. You could have worries about, if you're on a meter, a finger stick like this, where is my blood sugar heading? And so, people will start to check very often. If you're on a continuous glucose monitor, you may have worries that, like Melissa was saying, that it's going to go off in the middle of class, in the middle of the SATs, and it's going to disrupt everybody. And so you feel self-conscious. So it's not just about what the number is telling you, but it's also the added burden of having to do these blood glucose checks. Physical activity no longer becomes just a spontaneous, fun thing to do, or not fun, depending on who you are. But PE class is usually a source of great stress once you have CF-related diabetes. What time it is blocked into your schedule or your kid's schedule, and it may really disrupt life because it might always be right after lunch where your kid has dosed for diabetes and then they go low. It might be first thing in the morning when somebody is really insulin resistant and has really high blood sugars and feels really icky and yucky and doesn't like doing that. It may be like my husband who lives with type 1, who I'll text and I'll say, I have a noon break. I'm about to head to wherever to work out. Do you want to join? And he's like, I would have had to think about that 3 hours ago and planned for that. So it's no longer this easy breezy, spontaneous thing that people can do. And then food, which is the essence of humanity, right? We need it to live, and we also need it to socialize. It's something that we think about, we do. We have food here in the back of the room, and every meal becomes an added burden. Where are my blood sugars at? Where are they going? What can I eat? What can't I eat? And already food is so difficult for people with CF. So this added burden of CF-related diabetes really impacts all of these different facets of life. The new demands take a toll and can lead to diabetes distress. And what I like to say about diabetes distress, and this might be like a Debbie Downer move, but I think it's important, and I say this multiple times across people's lives, is that diabetes distress is expected. It is not rare. It is the norm. And you're going to have bouts. You're going to have ebbs and flows. Diagnosis can be re-traumatizing for families, for parents especially. Diagnosis for adults can be traumatic and a very traumatic experience that they've been dreading for their whole life, like Melissa was saying. You're going to have moments, and it's important to help, I think teaching the expectation that this is a natural part of life leads to when people start feeling overwhelmed and distressed, that they don't think, oh my God, what's wrong with me? Why am I experiencing this thing? Why do I feel hopeless or helpless? And so talking about how it's not only expected, but there's also lots of good treatments for it, and Michael will talk about treatments for it, is a really important thing. Numbers aren't just numbers. Out of range numbers feel like failures. I put can because I'm a psychologist and I hope that sometimes they don't, and that's what I try to help train, but they do. They feel like a good and a bad number. And we'll talk a little bit about how to talk about diabetes to try to overcome that. But an out of range number is always going to feel like a bad thing. People feel Like when they come to their clinic visit, if they take the A1C test and it's 6.5 or above, oh my gosh, I failed. What did I do? Or I failed my child. People get a lot of judgment from their self and from others. I'm not doing things right. I'm not managing right. And remembering that there are so many variables that go into how these numbers are. And in CFRD, there's even more than in type 1 or type 2 diabetes, because sometimes randomly your pancreas does excrete some insulin, and then that kind of changes everything up. Sometimes randomly you're on steroids and things go wonky. So the judgment and this sort of feeling like a failure, it's really important as you guys are treating folks and your treatment team to try to like disentangle that and name that so that people can see, wait a minute, no, I have these behaviors and I'm doing an excellent job, and I have these feelings and they will ebb and flow, but the one doesn't necessarily cause the other. Okay, yes. Are you depressed because you have diabetes, or is diabetes causing your depression? Both, right? It's a chicken and an egg thing, and people really struggle when they get this diagnosis. Okay, so the feeling overwhelmed piece is huge and contributes to burnout. So we all had breakfast. It wasn't this beautiful or delicious, but what do you all see, right? And what does somebody that's living with CFRD see? A mathematical problem. It is overwhelming. So you're thinking, what were my glucose levels when I woke up? Where is my arrow heading? Oh my goodness, are those fats going to hit my bloodstream at the same time or a different time than those simple carbohydrates? And how is that going to last 2 or 3 hours from now when I was planning to go to the gym? Oh my goodness. And I also have a presentation that I'm going to do. And I know when I get stressed, my blood sugars start to elevate. And so how's that stress going to impact that? And should I dose a little bit more than I normally dose for this breakfast that I have every single day, but I get a different number for? So it's no longer just a meal. It's no longer just catching up for brunch with friends. It's this whole mathematical complexity, and it's overwhelming. And so it's really important as the care team to talk about that, to talk about how this is a lot. This is not just a lot in terms of all of the added, things that we've already addressed, like insurance and care teams and new medical providers, but it's a lot in terms of daily management, lifetime management, and thinking about one's future. So overwhelmment is expected. And some days, I think people with CFRD just feel like crushed. Like no matter what I do, I'm not getting this right. No matter how I approach this, this is too much. And so really stopping and discussing and talking through that is important, and asking. So I know there's a huge protocol for all of us to be doing the screenings, and I don't know about your centers. I know about our center where it seems like people these days are just sort of circling zeros all the way down, even though we know that they're really struggling. And so as a care team member, really stopping and asking, how are you doing with this? In what ways are you feeling overwhelmed? In what ways are you feeling distressed? I think opens the door to setting that expectation and getting a real conversation out of it, instead of just sort of these automated, no, nothing has changed. Okay. So conflict becomes a challenge at times with a new diagnosis. And so why do you guys think that we don't always respond to each other in the most helpful ways? We all mean well, right? Our care teams mean well. Our parents mean well. Our kids, they're kids. They don't mean well. No, they mean well, but we don't always respond to each other in the most helpful ways. And what did we just talk about with diabetes? It's this overwhelming, stressful, often scary diagnosis with a lot of time spent managing at the most fundamental, crucial part of life, food and connection. And when we think about all of the stresses about this and all of the fears and worries that we're going to talk through, people are scared. People are tired. People are hungry. And when you're scared, tired, and stressed and hungry, I mean, who here has worked in the food service industry, right? It's not fun. people do not always respond in the most helpful ways. And so it's very important as a team, if you're the nutritionist, dietitian, or anyone, nurse, psychologist, I mean, anyone can wear these hats and help understand this, but it's important to ask, what are the ways that are helpful to support your diabetes? Whether you're an adult living with CFRD, or you're a parent of a child, or you're the child, the adolescent, or the college-age child, how can people be helpful, and how can they be perhaps hurtful? Because those kinds of discussions really open the door to problem solving and solutions. Parents and partners can nag, right? A partner can say, oh my God, like, every time you have cereal right before bed, your CGM goes off all night long, and I also can't get sleep. You already know that. Why are you doing that? Or parents can say, oh my God, every single day at lunch, I just watch from work as your numbers are rising and rising and rising, and I know that you didn't give yourself any insulin. It's just rising and rising, and there's nothing that I can do about it. So the nagging doesn't make things better usually. There's this disruption of daily life, and the activity disruption is not just for the people with CFRD. And I think, it is what it is. It's difficult, it's challenging. Helping people talk about that, helping people try to prevent and plan for these challenges is important. But at the end of the day, I don't know, like with my husband who has type 1, when we go out on a hike and he's like low all of a sudden, and I'm like, crap, I didn't bring any low supplies, I do get frustrated, and I do get a little bit upset at him or worried and scared about that. So, I make a plan to always pack and carry a big backpack with a bunch of stuff in it, and parents do as well, and other support partners do as well. But it's not just disrupting of the person that's living with diabetes life. It's disrupting of everybody's life. There's a lot of parent conflict because oftentimes, as you know, we don't always respond to each other in the most helpful ways. And we often come at life with very different expectations and very different styles of management. And so interparental conflict can be really hard. And this can be an added source for parents that are already struggling with CF-related tasks and management to also have something else to be stressed and worried about. And then parent-child conflict, where a parent is wanting a kid to do something and a kid is saying, I don't want to do that, and then they start to argue and fight about it. So all sources of conflict. I love this one. Yep. Stop overeating, stop drinking, stop staying out too late, stop fighting, stop worrying, stop eating sweets. What'd your doctor say? I don't know. I stopped listening. Okay. Fears, there are lots of fears, and, we can talk forever about fears, but I sort of think about fears in terms of the right now fears and the maybe later fears. But both are really significant, and it's important when you're talking to your families and people living with diabetes to try to understand kind of where these fears are and how they might shift over time, because it really does impact their day-to-day. So someone with a fear of going low, and they fear it's a good fear. Going low is awful. It's very dangerous. It's risky. It feels terrible. It could be very embarrassing if somebody passes out in the workplace or at school. And it could be very scary for parents. Their kid is going to college and they have a severe low and they're like out of reach, out of touch. So it will then trigger and motivate people to act in different ways, whether that's keeping their numbers high or avoiding diabetes altogether, or just like avoiding diabetes in specific circumstances. I have a lot of people that are like, yeah, I know I do everything I need to do at home, but when I'm at work, I never bring out my insulin pump. I never dose myself. Self-management, worries about, can we afford this? Have we run out of supplies? What are we going to do if our supplies, fail us? Even political climate can affect short-term fears. Is my insurance going to drop my child or myself because I have all these predisposed conditions? Is the insurance going to change and I'm no longer going to be able to afford insulin for whatever my copay is per month, and now it's going to be a couple $1,000s a month? And then all of the long-term complications as well. So are they going to have these microvascular and macrovascular complications? If my kid ever grew up, or if I eventually need a lung transplant? Is this going to affect my transplant eligibility? And then also long-term self-management complications and into adulthood, now that we see people living with CF much longer into adulthood, thinking about how am I going to care for myself as an older adult, and how am I going to make sure once I'm no longer, working or in my insured state, that these things are going to be options and possibilities. And so really asking people, what is it that they're afraid of? And is it in the now? Is it in the later? And how do they kind of work around those fears will shed a lot of light into their management behaviors, which again, Michael will talk about how to bolster. And then there's worries. So, and I think worries are a little bit different or distinct than fear. There's overlap, but worry can be diffuse. Worry can sort of pervade your thinking all of the time, whereas a fear of low might be for a very specific situation. Parents have tons of worries, like, I don't have any food in the fridge and I'm supposed to cook this healthy meal tonight and I just don't know how I'm going to get that. My gosh, is my kid going to be bullied at school? Can we afford everything that we need to have? Will my child have this happy, healthy future that I'm hoping for them? Do they have the right amount of help and support with the school nurses or people in their school? Are they going off to college, and is the resident assistant in their dorm going to understand what the difference looks like between a low and getting too drunk at a party? Will they be able to get insurance when they're an adult, or is that going to be a barrier? So lots of different parent worries, and asking about these, asking people what keeps you up at night is really important. And then there's lots of specific worries when you are the self living with CFRD, like how disruptive are these technologies going to be? Am I failing if my BGs aren't perfect? Am I going to do something that's going to end up messing up my health long term? Will I get to do the things that I want to do? Like most teenagers and young adults are interested in their social life and driving and having a boyfriend or a girlfriend, and all of those things they'll worry about. Is CFRD going to define me? And is it going to keep me from the things that are important in my life? Will this limit me in some way? And also, I have a million other things to worry about. I don't want to be thinking and worrying about this. So ways to ease the burden, which Melissa already touched on, is really going in slow and easy. So taking your time with the information and education. When people are scared, it's really hard to retain information. And we also know from all of our research that education does not equal behavior change. Just educating people usually doesn't do much. It's great to have the foundation there. They will need that over time, and will do that over time. But education, especially right at the beginning, is really hard to retain. An installation of hope, whether it's a patient story or positive news about technology and treatment changes, is really important. Helping anticipate that there's no failure in diabetes, it's all just trial and error. And it's also just information. So numbers are not good or bad, they're information. And helping them understand that emotions around numbers can make diabetes feel harder. So helping them by using terminology like within range or out of range instead of good or bad, or things like, why don't you check your blood sugar instead of why don't you test your blood sugar? And just very briefly, there's a new study on executive functioning, which I think instills hope. Comparing those with CFRD to those without, there were many null findings, which might be interpreted as a lot of resilience and adaptation of people living with CFRD. The treatment complexity was higher, as expected, for people with CFRD compared to those without. And though there's higher self-efficacy, self-reported self-efficacy, and lower concerns about privacy in folks with CFRD, adherence, barriers to daily care, anxiety, depression, self-reported executive functioning didn't differ at all between these groups of those with CFRD and those without. So I think this is a really hopeful study. And then I already talked about the discussing, really figuring out with families, and this is my last slide, about what is the right support. Everybody needs support. What does support look like for them? It's too big to handle alone, and really discussing how it's important for everyone in the family to get support, and it's important to have a support plan. And with that, I will leave you with Michael Harris.
I want to first start with, you'll see these bracelets. I'm not a Swiftie. I like Taylor Swift. I have a 19-year-old daughter, and this is how she shows love, so I'll accept it. When your daughter makes you something, you wear it. I also want to thank Dr. Snell and Naranjo for inviting me to be a part of this session. I'm a content expert in type 1 diabetes, so I do see young people living with CFRD, but it is not my specific specialty. Financial disclosures, I'm a paid consultant for Blue Circle Health. So I'm going to get into some really specific strategies anyone can use, regardless of your background and training. I think these will be really easy to implement in the moment. They don't take a lot of time, but they do require kind of some underpinnings of really understanding why you would take this approach. So one of the biggest challenges in diabetes is that you can do the same thing on 2 different days and get 2 different outcomes. That's the maddening part of this condition. So what is it to be saying I'm winning in managing my diabetes? Well, it's not the numbers, it's the behaviors. And so if you're in clinic working with patients and you're focused on the numbers, you're really starting to buy into this narrative that they have control over those numbers all the time. And so what I would encourage you to start thinking about is the behaviors that drive those numbers. If you do the behaviors over some sustained period of time, the numbers will probably fall in place, but there's no guarantee. But if you solely focused on the numbers, that becomes a very punishing kind of clinic visit. It's akin to losing weight. Some of us have to watch our weight. And so the example that I would give if we were going to take diabetes and transform it to weight is I would ask you to get on a scale 5, 6, 7 times a day, or you had a continuous weight management monitor that showed your weight fluctuations throughout the entire day. How punishing would that be, right? Because your weight fluctuates for all kinds of different reasons from moment to moment. And so what can you control in diabetes? There's 3 things: blood sugar management and checking, insulin administration, and carb counting. That's the win. You do those things, that's the win, right? Will the numbers fall in place? Like if you exercise in weight management and you eat right, eventually they will, but moment to moment they won't. So Deanna talked a little bit about this concept of diabetes distress. This is a concept that is pretty new to other health conditions. It's not as new to diabetes. What this is about is that for many, many years, there was assumptions made that if you have a complex or chronic medical condition, you also have higher rates of depression and anxiety. And the problem with that is we used measures that are confounded with disease processes, with medication side effects, with all kinds of things that don't necessarily indicate someone is depressed or anxious. The GAD-7 is the go-to for anxiety, and the PHQ-9 is the go-to for depression. And so there's 2 researchers, Susan Folkman and Richard Lazarus, who looked at kind of stress and outcomes, health outcomes. And what they found was that instead of using kind of a psychopathology model of you either have the symptoms of depression or you have the symptoms of anxiety, they looked at the cause of the distress. So some sort of event, some sort of uncontrolled experience that somebody had in their life. And that drove the emotional experience that looked like depression and anxiety. And so this isn't to say that people living with CFRD or diabetes or CF don't experience depression and anxiety. What I would argue is that you need to look at it with a more nuanced lens and appreciate that the demands of managing a health condition can become very emotionally challenging. And that isn't necessarily depression or anxiety. It also doesn't mean that you don't do anything about it just because it's not depression and anxiety. You do something very different. And so what would Folkman and Lazarus recommend if this was distress and not depression or not anxiety? What they would recommend is first educating patients that what their experience is expected. As Deanna said, it's an expected response to a very, very challenging situation. And that if you use the lens not of psychopathology, you use the lens of stress and coping, then what kinds of proactive coping, what kinds of adaptive coping can you implement to offset the challenges that you're having with your health condition? So normalizing the emotional response, stress management strategies, adaptive and active coping, and engaging in social support. So once again, a couple of the speakers talked about language being really critical. So many of you may think that this is kind of nitpicky, but having done this for 30 plus years, our patient population is very sensitive to the language that we use, and rightfully so, okay? Even words like glycemic control. Glycemic control has been kind of used in a way that suggests you actually have control over those blood sugars. When in fact, once again, as I told you, you can do the same thing on 2 different days and get 2 different outcomes. And so talk about like glycemia or hyperglycemia instead of glycemic control. Other words that we use are that a patient's sick or non-compliant with a health regimen. Who is non-compliant? Why don't we use that word? Willful children are non-compliant, right? That's really how we think of that word. And so it also sets up a dichotomy. In all the patients that I've served, there has not been one that has been fully non-compliant. It's just not possible. So it doesn't appreciate the continuum of which people behave around the management of their health. So it sets up a dichotomy and it's a pejorative. So we use words like adherence. Adherence is better. It's not great. It still suggests a dichotomy. And so I use simple terms like, how are you doing managing your diabetes or your CF, right? What does self-management look like? That allows them to talk about what's working and what's not working. And I always start with what's working. I never start with what's not working, right? Once again, these clinic visits can be really punishing. And if you set this up where they're just waiting for the other foot to drop, then they don't come back. Sneaking and cheating is a common term used in diabetes management. What happens when you get diabetes and all of a sudden eating becomes sneaking and cheating, right? Before it was just eating. Now it's sneaking and cheating. Once again, you use that terminology and all of a sudden you set up this exchange between yourself and your patients where there's a lack of trust and they don't feel like you really understand and they can't really share what's really going on. So words don't just matter in terms of our exchanges with our patients. Words matter in terms of how we talk to ourselves and so how we perceive ourselves. And the language that we use will predict. Oh, by the way, you can take whatever pictures you want of these slides if it's that important. The words that we use to describe ourselves will oftentimes predict how we might behave. So if you think about yourself in a certain way, likely you'll start taking that on. There's really good data to suggest that when you think you're sick, when you describe yourself as sick, you behave as if you are sick. And then that changes everything, right? There's a cascade of behaviors that become really, really challenging to manage the rest of your life. And so it's not just, once again, professional to patient, but it's our own internal dialogue that we need to help correct. And so I would argue that this is an opportunity for all of you working with patients to listen to that internal dialogue that our patients are having and help them to correct it, right? Help them to correct it. Okay, so this is once again, none of these concepts are really new. This is a concept that's been around for a very, very long time. The idea that we have both a thinking brain and an emotional brain. One side of our brain is this analytical, kind of thoughtful, logic processing side, and the emotional brain is just going after the things that we really enjoy and that are our personal drives, okay? me tell you a story about my brain. You may not want to hear this, but I need a new TV. And so I did my work. I think, I'm a relatively bright person. I looked at Consumer Reports. I found the TV, the exact TV that I wanted that fit my cabinet, right? Had all the things I needed. I went to the store and there was my TV. I was like, oh, I'm in luck. This is great. The problem was there were two other TVs right near my TV. There was one that was just huge and massive and had all kinds of really cool stuff on it. I was like, that's way over the top. There was another one that was a little bit bigger than mine and had a lot more kind of, cool stuff attached to it. And it was only $25 more. Which TV did I walk out of the store with? That one. What happened when I got home? It didn't fit my cabinet, right? So the point of this is that we think we're rational, thoughtful individuals, and most decisions are actually not made based on rational, logical thinking. They're based on emotion. And the exchange that we have with patients is we're just talking to the analytical brain. We are not minding the emotional brain. And so I think of this as like a rider on an elephant. The rider is the analytical, kind of thoughtful part of your brain, and the elephant is the emotion. Elephants get things done. And if you ignore elephants, what do? They create havoc, right? They go on stampedes. They do really bad stuff. And so what does an intervention look like? What does an exchange look like where you're actually talking to both the rider and the elephant? Okay? Very simply, is knowing that even though you're having this intellectual exchange with your patient around what to do, how to manage diabetes, whatever, knowing that when they leave, many of their decisions will be made by their own personal desires. And so you have to weave that in and share that as an expectation that when you leave the clinic, like I know, because I do this, you may be tempted to do this, or you won't do this that we discussed. What is the plan? So you're actually then considering and feeding what I call the elephant, right? You're giving the elephant a little bit so that it doesn't go crazy and stampede and destroy everything. Okay, so there's been lots of conversation about A1Cs. There's been lots of conversation about time and range. Back to my kind of comment about the fact that you can do two different things, similar things on the same day or in 2 different days and get a different outcome. How do you use those numbers, time and range? How do you use A1Cs? How do you use blood sugars in helping people to understand the management of their health condition, of their diabetes? And so what I do is the only time I use numbers is I will graph over a period of time in the context of their life, those values. And what that does is it allows them to see how life impacts health and how health impacts life. And I think that's a really nice way to then start talking about like, okay, so you were diagnosed, your A1C was elevated, obviously, because you didn't have insulin on board. All of a sudden, we got you insulin, it dropped down. Oh, and you started college. It popped back up. So you're starting to show them these patterns in your life of how life and managing life gets challenging around diabetes. Close friend died, we had an A1C spike there, and then finally got it on a CGM. So this isn't to devalue A1Cs or time and range. What this does is allows people to understand as you move through life that you have to expect that you will have challenges in managing your diabetes. And so what kinds of back to coping strategies are you putting in place to mitigate those elevations, mitigate those challenges that you may be having? Feels, once again, less punishing, less personal, and it's how life is. Context drives behavior. In the right context, we can do anything. In the wrong context, we can't do anything, right? Just think about that. Context drives behavior. Okay, so one of my areas of expertise is teenagers, so I'm just going to run through this really quick. If you work with teenagers, I love teenagers. I don't love my own teenagers. but I love the teenagers I work with. And so I wrote this paper about dogs, cats, and diabetes. I published a lot of work, and never anyone has asked me for any of the studies that I've published except for this editorial on cats, dogs, and diabetes. In fact, when I'm at the American Diabetes Association conference, many people know my name, many don't, but they'll say, "You're the cats and dogs guy, aren't you?" So you'll remember this. If you have kids, you'll remember this. So if you think about normal development, you think about the transition from childhood to adolescence being one of the most challenging. The reason it's challenging is mostly because we don't shift as parents to treating our children in a different way because they are different creatures, hence dogs and cats. If you have a dog, what are they like, right? They see you, you walk in the door, they're happy to see you, right? They roll over, they want to play all the time, they want to snuggle, they're easy to discipline, right? They feel really bad if you yell at them. They go in the corner. And that's what kids are like. And then they become cats, right? And think about what a cat is. Do you discipline a cat, right? Are they really affectionate? They are affectionate on their own terms, right? Are they independent? Yeah, they need you a little bit, but you can feed cats and leave food out, and they will just self-regulate. It's so amazing. And cats also do their best work at night, right? Very much like teenagers. And so I guess my point here is if you're working with the teenage population, is stop applying the same thinking around working with children that you would work with an adolescent. You have got to shift your frame. They still need us, but they need us in different ways, and they need a different kind of exchange with us. You can still be quite effective with them, but I guarantee you, if you're going to keep applying that same approach that you would apply to your patients who are younger, it's not going to work with teenagers. If you're interested, Deanna's husband and I wrote a book about teens with diabetes. It's a pretty easy read, and it can be helpful in terms of just understanding how to work with this population. Okay, so really quickly, the concept of psychological quicksand. What I see a lot of patients doing is that they are fighting with their health, and rightfully so. It's an intuitive thing. You have this thing, you don't want it, and you fight back, right? That's how you should behave. The problem is nobody has won the fight with CFRD, nobody has won the fight with CF, and nobody has won the fight with diabetes. And so it's kind of a futile fight, and so what happens is it's like quicksand as you fight with this thing that you don't want, and it gets a bigger grip on you. It's akin to the Chinese finger trap, the idea that as you pull your fingers apart, it gets a tighter grip. And so sharing this analogy with them and understanding, like, how do you get out of quicksand? How do you get, I've never been in it, but I've read about how you get out of a Chinese finger trap. Well, with quicksand, you increase your surface area with this thing, okay? What does that look like in terms of actual, implementation or operation? So the way you increase your surface area is you try to engage in activities that are involved with this condition that have nothing to do with clinic, have nothing to do with your health. So like the CF Foundation work, the American Diabetes Association, going on 5Ks, engaging in activities that have nothing to do with your personal health, have more to do with the community. You're increasing your surface area. And so there's a balance between the punishing side of your health, and there's a part of of your health that you're benefiting from being an advocate, being engaged with community, being with other people. Okay, so I would argue that the best intervention that any of you can do is focusing on social support. There are thousands and thousands of studies demonstrating how social support predicts morbidity and mortality. And the mechanisms of which this happens is really fascinating. It doesn't cause things like CFRD. It doesn't cause things like diabetes, but it is a major player as a psychosocial factor in terms of people's health. And so if any intervention you're doing is about engaging your patient in some sort of connectedness with other people, I think that's a really good time in clinic to be spent, because there are all kinds, and I can go into the specifics of all the benefits that come with being connected to other people. But trust me, across the board in terms of depression, anxiety, suicide, all these things are mitigated by our connection with other people. And so it also increases adherence, being connected to other people. I mean, the list goes on and on. Related to social support, I've been reading this book. It's really interesting. It's by Susanna Fox. She was the Chief Technology Officer at Health and Human Services during one of the past administrations. And what this book is about is exactly what I just described, is how people who share a medical condition use each other to create new ways to cope, to get treatment, to get access. If you think about diabetes, the great example of this is the DIY in closed loop, hybrid closed loop systems between pumps and CGMs. That's where that came from, that groundswell. And so using the value that each individual person brings is going to be beneficial. Okay, so I'm going to wrap up with focus on behaviors, not numbers. Context drives behavior. So play the long game, feed your elephant, change the way you talk. Remember that teens need you, but in different ways. Increase your touch points with diabetes, get closer rather than further away. Social support is the most powerful psychosocial factor in health, and diabetes distress is expected, and that you address that with adaptive coping. So I'm going to wrap up with this comment by a dear friend, Dr. Barbara Anderson: the most important drug in diabetes is behavior. Thank you.
Good morning, everyone. Thank you for being here. I am Nora El-Shar, 35 years old, living with cystic fibrosis and a bilateral lung transplant recipient. I am a Syrian-American humanitarian and global health advocate whose lived experiences as a post-double lung transplant recipient deeply inform my work advancing equity, compassion, and inclusion in cystic fibrosis care. Guided by both personal resilience and professional dedication, I strive to bridge gaps in access, amplify patient voices, and inspire a more humanitarian-centered approach to healthcare. I have spoken at numerous conferences and a co-author in articles, manuals, and further publications. Living with cystic fibrosis already means living with an endless list of to-dos. Treatments, medications, enzymes, airway clearance, clinic visits, and the list just goes on. It can feel like a full-time job, and truly it is, just to stay stable, but nonetheless, we do it. Then, imagine being told one day that you now have diabetes. Not type 1, not type 2, but something in between. Let's say a third option, which is a hybrid, and we call it cystic fibrosis-related diabetes. A whole new diagnosis, a whole new learning curve, and a whole new set of alarms, meters and routines added on top of everything else. For many, that would be overwhelming, and it is. But for me, it became over a decade-long journey of learning, adjusting, and ultimately redefining what thriving really means. When I was diagnosed with CFRD, I remember feeling this strange mix of frustration and disbelief. How could my body handle one more thing? CFRD is complex because it doesn't stay the same. It evolves with every season of life. When steroids increase, your blood sugars spike. During infections, they become unpredictable. When stress builds up, in my case, my blood sugars dip and drop rather than climb. Even my monthly hormone changes send things out of balance. So with all this said, we keep our providers on their toes. It's like diabetes gets re-diagnosed every few months, depending on what's happening in our CF world. And that constant change, that unpredictability becomes mentally taxing, tasking, and exhausting. For the first few years, I wasn't insulin dependent. I tried to manage with diet, timing, and physical activity. Now, walking that tight rope between stability and pure chaos. But eventually, my body needed more help. Starting insulin was intimidating. It means syringes, pens, carb counting, solving equations, adjusting doses, watching my numbers like a hawk. It led to a harsh period of depression. My mind could not see anything else except CFRD, period. On the other hand, taking insulin also meant freedom, a kind of control I hadn't felt in years. With insulin, I could finally nourish my body without guilt or fear. Still, that control came at a cost. A heavier mental load, more alarms, more decisions, all day, every day. CFRD doesn't just reside in my body. It occupies my mind, demanding vigilance and forever whispering thoughts, even when I need to rest. Over the years, technology has changed dramatically. I went from pricking my finger multiple times a day to wearing a continuous glucose monitor like I have one on today, and I'm hoping that it doesn't start going off while I give you this talk. And then with it, I didn't have to do any more pricking and could just check my numbers at my fingertips with just a tap, thankfully. And then came insulin pens, not just an insulin pen, but a smart insulin pen, which is honestly one of my best friends. That insulin pen logs every dose. It shows glucose trends, and it starts to tell me what's happening before I even feel it. This technology is empowering. It's life-saving, and it's crucial for those who have brain fog or forgetfulness due to medications or medical conditions like myself. I can look back now and know exactly how much insulin is still active right at my fingertips, and in which direction my glucose arrow is steering. But it also means the data never stops. Never. Your phone is constantly buzzing. High glucose, low glucose, trend rising. The numbers don't stop. The numbers don't sleep. And sometimes neither do I. I used to describe CFRD as a mental hum that never goes away. Even in silence, your mind is scanning. It's analyzing and often preparing for the next correction or the next meal. There were times I felt like I could never shut my brain off. Even at rest, my mind was racing, planning, anticipating, and worrying. And what did I do when I tried to take a break? It felt like hitting the snooze button on a loud alarm inside my brain. That noise would stop only for a moment, and then it would start again. CFRD doesn't just affect my blood sugar. It affects my relationship with myself. I start to see numbers as a reflection of success or failure. I feel guilt when they're too high, shame when I miscalculate a dose, and fatigue when I realize this cycle will truly never end. Can you take a walk in my shoes with me? That mental load is heavy and often, or I should say always, invisible. Providers need to be able to recognize these moments, these changes, not just mentally, but also physically. It took therapy, community, and grace to realize that I can't perfectly manage CFRD. I can only manage myself within it. Thriving, I learned, isn't about perfect numbers. It's about peace. Peace with the fluctuations, the uncertainty, and even the imperfections. And that realization changed everything. Today, when I look back at more than 10 years of living with CFRD, I see growth, not loss. I see a girl who once feared management of it all, the numbers, the alarms, the overwhelming mental load, now becoming an author and an educator. And that same girl's face today is on the cover photo of the latest CFRD manual for the Cystic Fibrosis Foundation, created to guide and comfort those newly diagnosed or those simply wanting to learn more. Let me assure you, and I will reassure you over and over, that this transformation did not happen overnight. It happened through countless days of trial and error, always, or fear and through resilience. And the decision that my story could serve someone else's beginning, that's what truly meant the most. Thriving for me means embracing the rhythm of change. It means knowing that even when the numbers are off, my worth isn't. It means giving myself permission to rest, to reset, and to keep going. CFRD taught me patience, humility, and compassion. It taught me that thriving isn't about perfection. It's about participation. Every day I wake up and engage with my health and use that experience to help someone else engage with theirs. That is thriving. If there's one thing I've learned, it's that CFRD may add noise to your life, but it also sharpens your awareness drastically. It forces you to live consciously, to listen to your body, and to find balance in that chaos that I mentioned. I may not be able to shut my brain off, but I've also learned how to tune it, like an instrument, to a rhythm that keeps me grounded. We may live with constant adjustments, but we are also living proof that resilience can coexist with fragility. And that thriving is possible, even through the noise. Now let's walk this road together with patience, teamwork, and grace. I would like to share a small piece with you from a publication that I wrote with another doctor, and it's called The Rules of Being a Patient. And I'll start here. What if we can take our experiences and use them to advocate for others? What if work became more than our stories, but a movement? We have been patients, but we have also been on the other side. And we know the rules. But maybe, just maybe, it's time to break them. Just a little bit. And I will end there and say thank you to everyone for listening.
All right. All right. Thank you so much to Nora and to all of our speakers today. We have some great questions that you all have entered in the chat, and so we'll do our question and answer piece now. If you would like to just raise your hand or stand up and ask a question in person, we can certainly do that as well. So we'll start with that and then go to the questions in the app. Does anyone have a question for any of our speakers? Wants to be brave and start. Okay. So we'll start with a couple more medically oriented questions here. One is it possible to have CF and diabetes that is not CFRD, i.e. type 1 or type 2? How do you determine the difference in a patient with CF?
That is a great question. And yes, it is possible. So for type 1 diabetes, often the presentation will be a little different. And so I typically will check for pancreatic autoantibodies, which are typically elevated in type 1 diabetes in someone who has a more abrupt onset of their diabetes, or if there's a family history or other clinical signs that maybe there's something else going on. And that doesn't necessarily change our management. We're still going to use insulin, but it does potentially tell us there's a higher risk of diabetic ketoacidosis where the acids build up. And so it's just helpful for guiding and informing and educating patients. Now, type 2 diabetes, we are seeing more and more evidence of metabolic syndrome, of insulin resistance that's happening in people, especially after modulator therapy. So people are gaining weight, and we're seeing kind of, more signs of type 2. And so that's, there's no real test that we can do for that. It's kind of a clinical diagnosis. And so for someone who develops diabetes and does have, a strong family history of type 2, or is in that overweight, obese range, has, acanthosis that makes us think that they have insulin resistance, then often, I will, consider that more of a type 2 spectrum, and I might start medications for type 2 diabetes. In general, my clinical experience now is that when you have someone who has type 2 diabetes, but they also have CF, I worry that their beta cells are still going to have the same, risk of decline and failure over time. And so I do worry that they will maybe progress faster to having insulin deficiency in addition to insulin resistance. And so that might just be starting these other type 2 diabetes medications may just end up being a temporizing measure. But we don't really know. We're still learning. So that's a great question.
And another one that may be primarily for you, what are your opinions on the use of GLP-1s in people with CFRD?
Another great question. I use these medications not infrequently in people with CF, both for treatment of obesity and for the treatment of insulin resistance, diabetes, and someone who's overweight or obese. I will say I'm very careful about who I choose to treat with this medication because there are side effects that we need to be aware of. So, delayed gastric emptying. I worry about, the GI, diarrhea, constipation. Want to make sure we don't see people get distal intestinal obstruction syndrome or DIOS, which is unique to CF. And then I also worry about excessive weight loss. We don't want to have them lose too weight. And then the pulmonologists get mad at me if their BMI is under our goal. But I will say we're seeing data come out now. These medications are good for their heart, good for kidneys, good for so many different things that in select patients, I absolutely will use these medications.
And for our psychologists, I'm going to paraphrase this one slightly, but are there findings around the prevalence of disordered eating or eating disorders in CFRD? Would the prevalence be similar in type 1 and type 2? And are there specific eating disorders screeners that would be useful in this population?
That's a really difficult question. I don't know the entire answer. And I think that it's not even known completely in type 1 diabetes. I don't know. That's a really tough question. I think that just about CFRD, I think that more research is needed. I think screeners. So it's a little bit different, and now with ETI things are changing, and we're working on a study and also another paper about obesity and adiposity, as well as the impact on nutrition and eating behaviors in people with CF, which is a new world, as you all know. And prior to now, I don't know that eating disorders or disordered eating was thought of much differently as CF diets, because CF diets were so disordered in their just having to eat everything and anything and having it be high carb. And, I think maybe 7 years ago, was it 7 years ago, where we did that study where families across the country had to do a sort of diet type of study, and the feedback that we got were from the Bay Area were like, we're not going to increase Oreos, like that's not healthy food. And in other places, people were like, well, we're not going to decrease Oreos. Anyway, so I think that it's complicated. It's changing with new treatments, and I don't think that we have a good read on what prevalence is or even how to treat it, but I would suggest having conversations about people's concerns about their bodies, and less of a, like, do you screen positive for disordered eating, and more of a, how do you feel about your physiology, about your physique, and how does that impact the things you're doing to help manage your illness? Because people are shifting and doing things. In type 1, oftentimes you see that people are omitting insulin in order to decrease weight. And in CFRD, it's not as simple necessarily, but we will start to see that as people are having bigger BMIs, larger BMIs.
I'll just weigh in really quick here. So the confound that Deanna referred to is that the measures that we use to assess for disordered eating or eating disorders are not calibrated to the specific meal plans and diets that are required to manage both CF and diabetes. And so you'll get a lot of false positives if you use those measures. The DEBS is probably the best measure. It's Lori LaFell and her team put out of Joslin. It is much more sensitive to the specific eating challenges of living with diabetes, so I would go there. And just to echo what Deanna said again, is that probably the best tool you have is to talk about the regulation of weight more than anything, and focus less on kind of how they're using food. Because if the perception is that they need to regulate their weight, that would be a key to start then investigating further.
Hello. Okay, there we go. I kind of wanted some feedback. I'm struggling with a patient I'm seeing for therapy that has a new diagnosis of CF-related diabetes, but it's really focused on her numbers. Her weight is still under 100 pounds, and she's like, well, I eat, and to manage my numbers, I get on the treadmill and I walk, and she's so fixated. And when she went to the endocrinologist, her A1C was normal, and I was like, hooray, it's amazing. But there was not the same response because her weight is still low. So I guess, how do you manage these competing, I don't know, any insight from like a psychological perspective? I'm really struggling with this patient.
Can I share just a personal experience? I was the very same when I was not using insulin. And I would be very active to try to burn off what I ate. And it's honestly very exhausting. And I reached a level where, like you said, my A1C was perfect and I was keeping my numbers under control, but I was malnourished. And my nutritionist told me, you're almost starving yourself, because I would worry so much about that number climbing. And that's when I was like, please, I need more help. And when I started using insulin. I know it's hard that you're saying they're newly diagnosed to also add in insulin, but believe me, that changed everything. Although, like I explained, all of the chaos that comes with it, that's just my personal experience.
I think just it's a great commercial for why we should have behavioral health specialists working in healthcare, because there's not an easy answer to that. And for those of you who have integrated behavioral health care specialists, whether it be social workers, psychologists, or whoever, leverage that, because this is not we have a slide on that and how to fix that. It's just as complicated as the medical part of managing CFRD. So lean on your behavioral health specialists.
Another question, is there a reason we wouldn't start people with a continuous glucose monitor right off the bat if it would lead to fewer calculations, less management, less stress?
I love this question. I would say no. I mean, I love CGM. And so when I have somebody with a new, diagnosis, it's the first thing that I pull out. If I have a new patient that I'm seeing who's doing finger stick checks, I really, really try to encourage, giving CGM a try. And almost everybody, once and many people I think are like, I don't want to be attached to something. I don't want people to see it. It's always there. And so, but once they try it and they see just how convenient it is to be able to look on your phone and see, what your numbers are, and it's just so much more information, and that usually almost everybody will then start using it for their clinical care. Now, I will say the times that I don't use CGM, that's actually changed for me. So initially, I gave CGMs to everybody. Like you just walk in the door and you get one. But what I have found is that, especially for people who are not on insulin, I think everybody on insulin, I think really could most likely benefit from CGM because of the risks of hypoglycemia. But the people who are not on insulin, I'll often use it for monitoring. And I used to give it to people who were having a lot of low blood sugars because, as you know, people with CF, even without diabetes, can be at risk for reactive hypoglycemia, where blood sugars after meals go high and then they drop low. And so what I found was that, it can be helpful for some people, but when you're using it for a reason, for hypoglycemic monitoring, it can often increase anxiety a lot because, well, number one, there's a lot of false lows. And so, if you sleep on it or squish it at night, it can, lead to a compression low, and that will wake people up from a dead sleep and, affect sleep. And usually that's not real. Also, it can, people can get so focused on it, like trying to prevent lows. And a lot of times we actually can prevent lows with changing diet and changing nutrition. And you don't need the CGM, because for like 99% of the time, the lows that happen when you're not on insulin are not going to be the dangerous kind. You know, and we can manage it without, you know, having such a focus that really can take over. So I'm very selective in and kind of who I would use CGM with when it's just for hypoglycemia. But I do think it also can be helpful for people, especially who are in that overweight or obese range. We're starting to see high blood sugars or people in that early CFRD, to see how different foods affect their blood sugars. And that can, I think, be a nice adjunct to behavior change. So I think you really, in general with CGM, for people not on insulin, you really want to make sure that you're doing it for the right reason and that the person that's going to help that person and not actually make their life worse.
Great. Couple questions in one here. On one of the earlier slides, it looked like there was a sharp increase in diagnosis at around age 10. Does that correspond with when most clinics are starting to test for CFRD? And if so, is there any discussion about benefits of lowering that age range to catch it earlier? Also, does early evidence show that modulator use among children could delay the onset of CFRD?
These are such great questions. So yeah, that increase that happens at 10 is most likely from screening and catching it sooner. But we know even in like little kids, like toddlers, that they don't have normal glucose. They do have these like, you know, excursions in glucose after meals. And we don't fully understand the implications of that. And so for CFTR modulators, and so what the other big thing is that we've recently learned in clinical trials is that, does starting insulin when you don't have actual diabetes, does that actually help you? And it seems like it might not. And so screening earlier in the younger population, you might actually see a lot of abnormal glucose tolerance, but you're not going to necessarily intervene. And the incidence is so low of frank CFRD in the under 10 population that you're probably going to do more harm than good for, increasing anxiety and screening. And it's hard to get those OGTTs done. So I don't know that we need to screen sooner. And in terms of the effective modulators, we're learning a lot. There have been multiple studies now that have shown that it does seem like there are small benefits in glucose levels and decreases in glucose levels with modulator treatment. It's probably multifactorial. So, people are healthier, less steroids, less inflammation, more activity, a lot of these things coming together. We have not seen conclusive data yet that, modulators will, make diabetes go away. We haven't seen that. And what we don't know is, will they potentially push off the diagnosis of diabetes? And I think the biggest question, and really, I think one of the most exciting things possibilities and the hope moving forward is that, well, if we start really young, could we change that pancreatic milieu that is, predisposing to that beta cell dysfunction and potentially stave off the development of diabetes? We just don't know, but stay tuned.
Can I just add to that also a personal experience? When I had my transplant, you're on very high steroids, so my sugars were really high and I needed to be on insulin. Before my transplant, I was taking a CFTR modulator. When I first got my transplant, the doctors stopped the modulator initially, and until they then agreed or saw that the modulators weren't just helping my lungs, but many other systems in my body. So when we restarted the modulators, within 1 week, I was able to stabilize my sugars and be off of insulin for a period of time before then I needed to get back on it. But that is just a small story about truly how it can be helpful.
Thank you. Does the work that companies like Vertex are doing on beta cells, is it likely to be beneficial for CFRD?
Oh my gosh, I'm just loving this audience. That is a great question. So Vertex they have a cellular therapy program where they're looking at stem cells that can be infused into the liver to kind of basically replace islet cells. The downside of what they're currently working on is that it does require immunosuppression. The trials are limited to type 1 diabetes right now. But I do think, especially for people who already have a transplant, already on immunosuppression, I do think that this could be very promising for people with CF. That's a really great question.
Right. What are some ways to talk about routine and scheduling meals with someone new to CFRD, as this could be something very new to someone that's more used to grazing?
You want me to take it? Okay, take it. So I would suggest go slow. Behavior change, white knuckling it never works. It's a recipe for disaster. So figuring out ways that somebody could just incrementally start to change their eating habits to accommodate the regimen, as opposed to trying to do everything that's being asked of them in a more structured way, especially for somebody who's grazing. The advantage, and maybe I'm not fully understanding this, the advantage of all the technology we have with managing diabetes is it allows for grazing, which is kind of cool. So it frees people up so they're not having to be tied to eating specific meals at specific times with a specific amount of carbohydrate. So I guess the second piece I would encourage your conversation with your patient about is how to leverage technology so that they can be somewhat unencumbered with eating by using technology.
All right. And next up, at what age do you recommend checking hemoglobin A1C?
So I think hemoglobin A1C can be helpful because there was this idea that, A1C is falsely low in people with CF, and that's why we can't use it as a screening test. But it turns out that, we did studies with Dr. Scully, who's in the audience, that, A1C is accurate. It does reflect average glucose in people with CF. And so it is meaningful, and a change in A1C is very meaningful. And an A1C of 6.5 or above is diagnostic. So it can be helpful. I do like looking at the change over time. And so I think in terms of the youngest age, I think at our center, we check it in everybody all the time. And we did actually have one patient who ended up presenting much earlier than we would have expected with an A1C of above 6.5, who ended up having another genetic cause of diabetes called MODY. So I think, intermittent checking A1C, and I don't know that we need a lower limit to add that on to, a patient's annual labs. But I think it's most important in that 10 and above range.
Can tools like the Diabetes Distress Scale and the Parents DDS be used with CFRD to gain understanding of diabetes distress, or is there another tool that you would recommend? So I have thoughts on this, but if others do first. Yeah. Okay. Yes, I think that the DDS, while not specifically developed for CFRD, has a lot of useful items and subscales about just the overall impact of CFRD. We also have recently written up a paper in which we adapted the diabetes distress scale to CF in general, not just CFRD. So it has a CFRD item on it, but goes over the same sort of domains of how does it impact functioning, what's the emotional impact, and other areas. So I don't know if you'd like to add to that.
Have you been using it in clinical care yet? That survey, that sounds great.
Selectively with patients, but not across the board yet.
Yeah. That's awesome.
And the most sort of upvoted question, have modulators reduced the risk of developing CFRD in people with CF? Does that vary by genotype?
another great question. So we're still learning. I will say we do know from like ivacaftor, for example, since we have a lot more data on the ivacaftor population since it was out earlier in 2012. And when you look at registry data in the US and in Europe and pool of that, it does look like those people with the G551D mutation who are on ivacaftor had a lower incidence of new diabetes diagnoses over, I think it was 10 years period of time. And that was compared to people with, that were matched, not exactly, because obviously G551D patients are different, but it was matched to a comparator cohort. And so that does suggest that maybe there will be. Now, the downside, though, is that, with all the weight gain that we're seeing with modulators and insulin resistance and metabolic syndrome, we might actually start to see more of a type 2 phenotype that could drive more beta cell failure. So I feel like, I don't know, but I do think we as endocrinologists and CF will always have a job. So
I'm interested in prevalence of that. Are you guys diagnosing people with type 2 versus CFRD just for keeping prevalence rates?
Yeah, no, there's really no way to know for sure. And what I do is I usually diagnose people with CFRD with type 2 characteristics, or the other name is CFRD metabolic syndrome. So CFRD MS. And because there's really no way to know for sure what the drivers. And but I do think what ends up happening is you have the underlying, pancreatic, badness that's causing the beta cell dysfunction. And then you're adding another kind of challenge to those poor little beta cells by increasing insulin resistance. And I worry that what we'll see is it's not really exactly a type 2 phenotype because those beta cells are more prone to failure because of what's going on in the pancreas. And so I do worry that we might be like, oh yeah, that person with CF has type 2 diabetes, but those beta cells are going to actually fail sooner and their insulin is going to be needed sooner. And those type 2 medications that target insulin resistance aren't going to be enough on their own. But we really need, these studies are happening to figure this out like right now. Like we are in it right now trying to figure out exactly that. So.
Can I come back to the DDS question or comment? One of my pet peeves is that we screen people for a lot of different things and we don't do anything about it. And so I think I would ask that people use screeners as a beginning of a conversation with patients, and that everybody who has a touch point with patients has the opportunity to leverage that screener in a way to improve care and improve that individual's mental health and physical health. So, using the DDS2 is a great tool in terms of 2 questions. Right away if they are showing levels of distress, but that's the beginning of the conversation from a healthcare professional to the patient about what are the next steps. And like I said, there's not enough psychologists, there's not enough social workers working in the business. We need all hands on deck to handle the behavioral and emotional impact that CFRD, CF, and diabetes has on individuals' overall emotional functioning. So please don't just screen, use it, do something about it, and know that you have the skills to do that regardless of what your background and training is.
Ahmed has a question.
All right. I know I had a question for Noor and also for others, just because diagnosis of CF, really impacts the way people behave, and also the big one is travel. And you love traveling, we know that, but it took you a long time to be able to take that next step. But traveling with diabetes, and all the other things that are going on with you, and for those who are newly diagnosed who may not want to leave, the safety of their care team. How did you manage that?
There's so much that can be spoken to this, but I will share. I do love to travel, but it did take a very long time to believe in myself and feel a little comfortable doing so. I will give you an example. This summer, I traveled to Syria. Now, I told you, a CGM. I use one of my best friends, my smart pen. In Syria, I did not have access to Wi-Fi all the time. So I was not able to get access to checking my phone and seeing what my CGM was, or my InPen and telling me what was active versus what was not active. So I had to go back to, I could almost say, the old-fashioned way, and prick my finger and check my blood sugar manually and give myself insulin and really just listen to my body and move forward like that. Everywhere you go, depending on the place that it is and what you have access to, will always dictate how you're going to take care of your diabetes. So that, for example, I always have, depending on how long I'm going to be there, I always have an extra CGM. I always have an extra cartridge of insulin. You never know what happens. I almost debated yesterday, should I put one in my cooler or not? And then I was like, I have to, because if you drop this, the cartridge inside is glass and it will break. And I was like, my luck, that might happen. So things like that, you just have to plan ahead. And I always like to have extra of everything, even my meter and all of that, so that when you have it, you don't need it. But, and then, like I said, I'm just monitoring on the plane while I'm just checking like how things are. But again, you're not always going to have access to that amazing technology, and you have to learn to work around it.
So basically what we're talking about is anxiety,
Yeah.
right?
Yes.
How do you help people manage anxiety around their health? One of the biggest mistakes we make is we try to basically cajole people into not being anxious, right? You're going to be okay. You got to do this. You got to do this. The problem with that is that anxiety serves a really important purpose, as we just heard, right? Not enough anxiety makes us unsafe. Too much anxiety immobilizes us. So calling it what it is and saying, this is important. It's important for you to be anxious about traveling, given your health. What do we use anxiety for? It's to prepare ourselves to be safe. And so what we just heard was a great example of how she prepared herself to be safe in managing her CFRD while also traveling. And so I think starting at that level helps people to be okay with, like, I'm okay being anxious about this. You should be anxious about this, right? It's important. Once again, it keeps us safe. And that frame, I think, settles everything down a little bit, but also puts it in a frame of, like, if you weren't anxious about this, you may travel and then be in a really bad spot. And so I think this is a good thing that you're worried about traveling given your health. If you're too anxious, you're never going to go anywhere and your life's over. And so how do we find that balance?
I just want to add one more thing. One of the first times I was traveling, I at the time had a G tube and my CGM and whatnot. And when you're going through security, these things show up, and they start to have all these thoughts in their head. And I was stopped in Paris and taken to this closed room to do a whole check. They were pulling on these things. They did not understand that. They just wouldn't comprehend that these are medical devices. After that trip, I never traveled again without a medical letter that literally explained every single thing that I have and that I carry with me, that I wear a CGM on the back of my left arm, and so that when I go in and they see it, they know, even that I have a portacath inside, because again, it shows. Please help any patient of yours who's traveling by giving them a medical letter that explains these details, because it's been so helpful.
Hi, I'm just curious. I happen to struggle with anxiety too, and what comes with that is a lack of appetite for me. So, given all the anxiety that this creates, how do you balance trying to eat with lack of appetite and all that kind of manage your diabetes with that?
Well, I'm the same way. And it's hard. It's really hard. I can go like long periods of time with just not having an appetite and not being able to nourish myself. And so I have to become very mindful of having things in front of me. Like, for example, if I'm working on a presentation, when I was working on writing my paper, I just had like a plate with all these different options on it. I had it in front of me. This way, while I was working, it's almost like you're almost a distraction that you're doing your work or you're doing something else, but you're grazing a little bit. And I'm mindful of the things that I choose so that there are things with sugar, but also with protein. And this is really like the best way for me, or like if I'm going to be leaving the house and I don't have the appetite, but I include in my bag like a bag of grapes, a bag of pretzels, cheese and crackers, and they're just there. When it's there in front of you, it makes it so much easier. I know that that's not always possible, and sometimes it just like goes over your head because that does happen to me, but you feel a huge difference in your body with the energy that it gives you when you are nourishing yourself. Because that lack of eating, lack of appetite, anxiety, when your body's getting weaker, your anxiety is just going to increase and become worse. So this is just my personal experience, and I definitely am the same way. And that's why I shared that when I am anxious or stressed out or whatnot, my blood sugar actually dips rather than climbs. And it's because I'm burning so much of what's inside.
Great, and that worked out very well in terms of time. So we are at time now. Thank you all so much for your great questions and for your attendance. And thank you to our great speakers.